We have to move really fast. The next talk will be given by Dr. Julio Garcia Aguilar. I count at least 6 presentations during the last 2 days mentioning your study in rectal cancer, but you're gonna talk today for a more tough issue, I think, which is, do we have any hope in systemic treatment of colorectal cancer in general? We're just waiting for a good news the last 15 years. We haven't seen any major improvement in terms of new drugs. So we are waiting the answer.
So thank you to the organizing committee for having invited me to talk about this so amazing topic, which is I do every day on my normal practice. So let's get to talk about the role of immunotherapy in the treatment of colorectal cancer, if there is any hope, and how can we improve the current therapeutic panorama. So I'm going to structure my talk in 3 parts. We're going to talk about an overview of immunotherapy in cancer, why immunotherapy is a hot topic in the current therapeutics in cancer, trans-tumor type. Also, we're going to discuss why immunotherapy is so awaited in metastatic colorectal cancer, and finally, we are going to review the different immunotherapy strategies for the different subsets of metastatic colorectal cancer. So, as a matter of introduction, let's start from the very beginning. As we see in the slide, we see how immunotherapy is a completely different way to treat cancer to what we are used to. We see here how the tumor, as the tumor progresses, we see how the tumor progressively escapes from the immune surveillance and how the immune elimination and the immune surveillance progressively decrease as the tumor progresses. While normal treatments against cancer are focused into kill tumor cells, so are focused in this compartment in immunotherapy, we are focused in how to engage the immune system to push it to recover the initial situation where the immune system recovers the ability to eliminate colorectal cancer or other tumor types. So why is this so important? This is important because we know since 1980 and early 90s that we can cure metastatic patients with immunotherapy. So if we are able to engage the immune system, the immune responses can really cure patients because the immune surveillance and the action of the immune system on the tumor is 360 degrees surrounding the tumor, so we can really eliminate. This is data from melanoma patients, metastatic melanoma patients treated with high-dose intravenous interleukin-2, and we see how more than 10 years follow-up, we can cure almost 1/5 of the patients. And this is data from the adjuvant setting in melanoma with the adjuvant treatment with interferon alpha, how the curves really separate. So with that, this is the situation why immunotherapy to be so awaited in cancer. However, it's a very complex situation, very complex scenario, because once given normal therapeutic strategies are taking place in a one compartment model. So we have the tumor, we only need to understand the tumor and how the tumor resists or responds to our therapeutic intervention. While when we are doing immune therapeutics, we have a 2-compartment model. We need to understand not only the tumor and the mechanisms of resistance, we need to understand also the immune system, and importantly, how the immune system interact with the tumor to get us the responses, the resistance, toxicity, responses, everything. So it's a significantly exponential, more complex way to treat cancer using immunotherapeutics. Here you see an illustration of this fact. This is a dramatic case from Memorial Sloan Kettering Cancer Center. This is a melanoma patient treated with ipilimumab and CTLA-4 monoclonal antibody treated by Jet Bolchok. And you see how this patient at the beginning of the treatment, we cannot even see any liver lesion, but during the treatment it appeared these big lesions here that point out maybe a progression, a disease progression. However, since the patient were doing better, instead of having a decrease in the general conditions, physician and Jet Walker continue with the treatment, and we see this dramatic response after this pseudoprogression. And this is what we call pseudoprogression, and you see the changes in the tumor volume, and you see how complex situations could be in immunotherapy. Another situation that gives significant complexity to the field is the toxicity that we can see. This is the data of the toxicity of high-dose interleukin-2, and due to this toxicity that could lead the patients to fall into atrial fibrillation, supraventricular arrhythmia, cardiac arrest, shortness of breath. So these patients that received high-dose interleukin-2 needed to be treated inside the intensive care unit just for surveillance and follow-up. So this is another complexity of immunotherapy, that we can have unexpected toxicities and very severe. This is the explanation why the situation is so complex. So the immune system is even more complex at the molecular level than normal tumors. So if we have not been able to understand completely the tumors at the molecular level, imagine how difficult it would be to understand not only the tumors but also the immune system. Here you see the cycle of the immune response, how this works, the anti-tumoral immune response. So we have the tumor here, and we see how the tumor antigens are recognized by antigen presenting cells. These antigen presenting cells go to the lymph node, present the antigens to the lymphocytes, and then the reactive lymphocytes become activated, go out from the lymph node and travel throughout the blood vessel until they arrive to the tumor, and then identify the tumor cells that express these antigens and then kill the tumor cell. So there are significant number of cells interacting with each other, so it's very difficult to have any influence in this so complicated immune cycle. However, with the appearance of the modern immune therapy drugs, modern compared to interleukin-2, interferon or so, since there are the anti-CTLA-4 monoclonal antibodies and anti-PD-1 axis monoclonal antibodies, the situation completely changed, and we were able not to have better toxicity rates and better toxicity profiles, make it not necessary to have the patients in intensive care unit to receive the treatment, but also being able to expand the benefit to the vast majority of tumor types, as you see here, with melanoma that we already discussed, but also lung cancer, head and neck, urothelial, triple-negative breast cancer, gastric, and so on. So we have now, with the more modern agents, we are able to treat more patients and provide benefit to more patients, and also we have a better safety profile. And this is what really makes the difference and make that immunotherapy start to become a hot topic in oncology right now. So now let's see what's the situation in colorectal cancer and what this whole topic is very related in colorectal cancer. So as you see here, the overall survival of metastatic colorectal cancer patients has increased progressively over time, mainly due to the incorporation of new therapeutic agents, chemotherapy, but also molecular-driven agents to the standard of care. And also due to a better patient selection, we are now able to provide 37 months of overall survival to our patients in the best case scenario, which is a left colon RAS wild type, BRAF wild type treated with anti-EGFR monoclonal antibodies plus chemo in front line. So the situation improved significantly. However, there's a significant frustration in the therapeutic panorama for the refractory patients. So once one patient passes through all the therapeutic options and becomes chemorefractory, we have in front of you the illustration of the population. So we have a population that merits being treated because they do very well with PS of 0, PS of 1, just minority of patients with ECOG 2. So these patients want a treatment, you want to treat them, but you don't have any good bona fide therapeutic option for them. So this causes significant frustration. So what we have? So we have a minority of patients with colorectal cancer that harbor concrete molecular alterations that could lead to dramatic treatment benefit to certain molecular-driven therapeutic options. But as you see, this is a minority, less than 1/4. And for the rest of the patients with chemorefractory metastatic colorectal cancer, the only options we have are these two that you see here. One is regorafenib, a multi-tyrosine kinase inhibitor that blocks near 300 tyrosine kinases, and the other is trifluridine, which is an anti-DNA agent. So both agents provide, let's say, a modest therapeutic benefit to patients because regorafenib can only improve the overall survival of patients 1.4 months compared to TAS-102, trifluridine, which improved 1.8 months. So it's a modest improvement, and in certain cases, particularly with regorafenib, at a cost of a severe toxicity rates. So this is the reason why immunotherapy is so wide in colorectal cancer, because if we could replicate the results seen in other tumors, we can impair and improve indeed this situation. Very frustrating. However, when the first immune oncology agents were tested in colorectal cancer, we saw how there were no activity. Here you see the response rate reported for ipilimumab, anti-CTLA-4, nivolumab, anti-PD-1, pembrolizumab, anti-PD-1, and atezolizumab, anti-PD-L1 in the unselected metastatic colorectal cancer population. So no activity in colorectal cancer if we don't select the patient. However, we got a very groundbreaking finding is led by the group in Baltimore, that was led by Dan Lee, you see here. They realized that, okay, for the unselected population of colorectal cancer, which is the figure here, we don't have responses. However, there is a subgroup of metastatic colorectal cancer patients that you see here that harbor a significantly higher number of average mutations per tumor. And these tumors were the ones harboring microsatellite instability. So the MSI high patients that accounted for near 5% of the metastatic colorectal cancer. And they realized that this concrete and rare molecular population were more infiltrated with T cells. Here you see T cell infiltration in brown and the tumor cells in blue, compared to the average colorectal cancer. And they said, okay, if they have this more number of mutations, so more antigens to be recognized by the immune system, and they have more T cell infiltration, so they are recognized by the immune system, why don't we treat these patients with immune checkpoint inhibitors? And they gave to them pembrolizumab, and they found this very groundbreaking discovery, is that all the patients from this group that you can follow in red, the vast majority of them responded and have long-term benefit, while the average colorectal cancer, the non-MSI high patients, never benefited from the treatment. So they were able to really identify the population to be treated with immunotherapy, which is the MSI high colorectal cancer. After this discovery, we had the nivolumab data. Nivolumab is another anti-PD-1 monoclonal antibody, similar to pembrolizumab, the one we saw in the previous figure, and we saw 35% of response rate, and very interestingly, almost the half of the patients were alive 1 year after starting therapy, which is very, very promising. You need to compare this with regorafenib. Just only 21% of patients are alive 1 year after starting therapy, compared to almost the half. Or with TAS-102, tifluridine tipiracil, where we only have 27% of patients. So very interesting results. And even more interesting, you see here how the patients that achieve at least a partial response, this is partial response or complete response, never progressed during the follow-up of the trial. So this means flat curve in overall survival, which means curation, at least during the follow-up of the trial. And this is the situation. And in this situation, FDA decided to approve pembrolizumab and nivolumab for MSI high colorectal cancer when they progress to standard therapy. However, I must say that in Europe these options are not available because EMA decided to wait until randomized data will be disclosed, because the approval of these agents in the States was made on the basis of a small phase 1 trials that I just showed you, but for European approval, EMA wants to wait until the pembro trials that are randomized against the standard of care. EMA was aware whether the MSI high status could be prognostic and could justify by itself the outcome of the patients, and this is the reason why they are waiting. So, future steps in the hypermutant colorectal cancer, MSI high. So what we are looking for right now is trying to improve even more the efficacy by combining anti-PD-1 inhibitors, which is nivolumab, with anti-CTLA-4 agents, ipilimumab plus nivolumab, trying to move the treatment to earlier lines, because the evidence is for the refractory setting. We need to move this to second and front line, so we have several trials exploring that, and trying to expand this low 5% of patients that could really benefit from this strategy. 5% is a very low number. Here you have the data on the combination of ipilimumab plus nivolumab. You saw how with nivolumab single agent we had 31% response rate, and these patients never progressed. So with the combination nivolumab plus ipilimumab, we have 51% response rate. We don't know yet, but if we see the similar phenomena that we saw with nivolumab single agent, that the patients that respond don't progress, we can have these outcomes in almost half of the population. These are the comparison of the two strategies. Nivolumab single agent in terms of PFS compared to nivolumab plus ipilimumab. You see how the combination do significantly much better. And also in terms of overall survival, you see how the combination do better compared to the single agent, nivolumab single agent. And very interestingly, for the combination, compared to the half of the patient being alive 12 months after starting therapy, you had 85% of patients being alive 12 months after starting therapy, which is very interesting data. And how to improve this 5% of patients, because the data is very good, but it's for a minority of patients. How to improve the percentage of patients. So we are following different strategies. What we are trying to do is we are trying to classify the colorectal cancer in a different way, just to identify the molecular mechanisms that could make them sensitive to different therapeutic strategies. So for that, we are trying to use the consensus molecular subtype classification. I don't know whether you are familiarized with this classification, but it's a classification that tries to classify at a molecular level colorectal cancers, not based on genetic mutations that we can find in the DNA. They are using RNA profiling just to classify at a transcriptomic level the different kinds of colorectal cancer. And they found out 4 different types of colorectal cancer. The CMS1, which is the MSI immune, because this 14% cluster with the MSI patients. And with that, I'm giving you the answer how we are trying to expand this percentage of population of patients that could be sensitive to immunotherapy. So if we have 14% of patients behaving like MSI high patients, but not being MSI, we can treat these 14% of patients with immunotherapy and see what happens. Also, we have the canonical subtype CMS2, the metabolic subtype CMS3, and the mesenchymal subtype CMS4 that we are going to discuss in a while. So this is the illustration of how we are doing. So we have the MSI and we have the CMS1. We see how part of the MSI clusterizes inside the CMS1, but by using the CMS classifier, we could expand this 5% up to 15% because all the tumors behave similar at transcriptomic level. And there is one clinical trial called Multicolor that is exploring the combination of anti-PD-1 plus bevacizumab in this population to see whether we can replicate the efficacy we saw for MSI high patients with immune checkpoint inhibitor single agent. But what about for the rest of colorectal cancer? What about for the 95% of the non-MSI high patients? What are we trying to do? So we see how these 95% of patients have a very low mutational tumor burden. So this means low neoantigens, low things that the immune system could recognize as something strange committed to tumor. We have low immune cell infiltration because of this fact, and we have no response to classical immune checkpoint inhibitors. So what we are doing? So we are also using the consensus molecular subtype classification to find the things to drag this concrete population. So we have the CMS2 and the CMS3. We have CMS1 is what we already discussed. We have that they are immune excluding tumors. You see that for the main immune traits, we don't have any activation. We have a downregulation of immunotherapy. So these are tumors that are not longer recognized by the immune system. They are what we call cold tumors because they don't have any immune response against them. And we have the CMS4, which is a hot tumor because we have a significant immune activation, but we have immune activation for the immune suppressor cells from the complement cascade and for angiogenesis. So it's a bad inflammation. This is not an anti-tumor inflammation. This is a non-specific inflammation that wouldn't lead us to an immune response. So for the CMS2 is this subgroup of here. What we know is that this subgroup depends on Wnt activation. So this subgroup depends on the Wnt pathway activation. And we know that the more activated the Wnt pathway is, you see here, a tumor with a low immune Wnt signaling, medium immune signaling, high immune signaling, and super high Wnt signaling, we see how the more activated the Wnt pathway is, the less immune response we have, because the Wnt activation leads to like a sanctuary tissue where the antigen-presenting cells cannot get into and cannot take the antigens to present to the immune system. So for this subgroup of colorectal cancer, there are trials exploring Wnt inhibition together with immune checkpoint inhibitors. For the CMS3, which is the group that depends on the metabolic reprogramming, this is the metabolic subgroup, you see how there is an intense overactivation of the metabolic genes in this tumor compared to the other three consensus molecular subtypes. We know that this metabolic reprogramming depends on Wnt and MAP kinase pathway activation, which mainly through the acquisition of KRAS mutation that you have here, but also due to other molecular alterations that lead to a MAP kinase pathway activation. So for this, what we are going to explore is the combination of MEK inhibitors together with immune checkpoint inhibitors. And let me illustrate the rationale behind this. So we know that when we have a tumor with MEK activation, we know that there is an impaired antigen presentation. MEK activation decreases the expression of the major histocompatibility complex type 1, which is the protein that presents the antigen to the lymphocytes. So when we block MEK, you see here in this pink bar, we increase T-cell infiltration, CD8 T-cell infiltration, we increase PD-1 expression, so we are increasing activating T-cells inside the tumor, and we are increasing interferon gamma production. Interferon gamma is the mediator that lymphocytes produce to inflame the tumor microenvironment. So if we are increasing interferon gamma, we are causing an anti-tumoral immune response. So by blocking MEK, we are doing all of these facts. So there was a trial exploring MEK inhibitor plus pembrolizumab plus atezolizumab in patients with colorectal cancer, and the results for the unselected population, non-CMS3, were 8% response rate. However, we got 10 months of overall survival and 1.9 months of PFS. But very interestingly, we got numbers comparable to nivolumab in MSI. We got almost the half of the population alive 12 months after starting the therapy, which is very interesting in non-MSI high patients. So trying to enrich the trials with this combination with CMS3 patients which have the MAP kinase pathway activation could lead to better outcomes, maybe. So now we have a phase 3 trial exploring this combination. We have cobimetinib plus atezolizumab versus atezolizumab single agent versus regorafenib, which is the control arm. And the results of this phase 2 trial could answer the question whether this combination could be a bona fide combination for the non-MSI high colorectal cancer patients. The results will be disclosure, will be communicated in the World GI in 1 month. And finally, for the last consensus molecular subtype, which is the CMS4, this group is led by a TGF-beta pathway activation. TGF-beta pathway activation leads to a very hypertrophy of the tumor stroma with significant number of blood vessels and significant number of fibroblasts and fibrosis in the peritumor stroma. And we also know that CMS TGF-beta activation leads to intensive chemoresistance and immune evasion. So for this particular cluster of colorectal cancer, combination of TGF-beta inhibitor plus PD-1 inhibitors could lead to a significant benefit. This is a paper recently published in Nature by Oriol Valle group, demonstrating how the combination, you see here in violet, the combination of TGF-beta inhibitor plus anti-PD-L1 agent could lead to intense tumor infiltration by lymphocytes and dramatic tumor responses. So for this group, we are going to open trials combining these two drugs, trying to make them immunosensitive. And finally, we have a final group of immune oncology treatments that we call transversal agents that could be active in all the different subtypes of colorectal cancer, regardless of the molecular alterations behind the different groups. One is the combination of immune checkpoint inhibitors plus radiotherapy plus chemotherapy in different settings. We know that radiotherapy, we know that chemotherapy cause more mutations into the tumors and cause very intense inflammation into the tumors. So this inflammation is synergistic with the immune activation that follows an immune checkpoint inhibitor. So we are testing that as a way to treat the vast majority of colorectal cancer and to make these cold tumors hot tumors that respond to immunotherapy. That's one of the strategies. The other are, and this is a very interesting one, bispecific monoclonal antibodies. Why is a bispecific monoclonal antibody? It's an antibody that on one hand binds to the tumor, to a pre-specified tumor antigen, and on the other hand binds to the T-cell receptor, the receptor of the T-cells, and cause an artificial immune response against the tumor cell mediated by the antibody. Here you have the illustration of this fact. We have a tumor cell here, we have the lymphocyte here, we have the normal antigen presentation, we have the major erythropoietic complex, we have the tumor antigen here presented to the lymphocyte, and this is the T-cell receptor. So you can have this and you will have an immune response, but alternatively you can have the drug that binds to CEA, which is the tumor marker. So binds to the CEA and then at the same time binds to the T-cell receptor, activating artificially through the antibody the lymphocytes against the tumor. This is one drug by Roche that is being explored in two different phase one in single agent, you see here the data, and the other in combination with atezolizumab and PD-L1, and we see how the responses distribute in different dose levels in the monotherapy, but very, very interestingly, in the combination with atezolizumab, the vast majority of patients treated at what we call biologically relevant dose, which is above 80 milligrams, the vast majority of patients treated above 80 milligrams benefit somehow from the treatment. And this is how these patients do over time. We see how all the patients treated, the 11 patients treated at the biologically relevant doses, had some degree of tumor benefit, of benefit from the therapy, and in some cases are very long-lasting. Now this is very groundbreaking in non-MSI high colorectal cancer, heavily pretreated refractory to normal therapy. And finally, the last strategy we are using to inflame the non-hypermutant colorectal cancer patients is trying to use substances that artificially could inflame the tumors, like oncovirus are. So by using oncolytic virus, we can administer the oncolytic virus either locally or either through an intravenous infusion for some of them, and the virus can get into the tumor microenvironment, infiltrate the tumor cells, and make these tumor cells able to be recognized by the immune system. So we are artificially inflaming the tumors by inducing by infiltrating with the virus. And then if we combine this with anti-PD-L1, this is the illustration of one trial ongoing, combining the oncolytic virus with nivolumab, perhaps we can have synergies. We are going to see this in this trial that has a dedicated cohort to colorectal cancer patients. So in conclusion, immunotherapy is the new standard of care for the 5% of MSI high metastatic colorectal cancer. Even in Europe, when we have the randomized data, I'm pretty sure that this will become the standard of care, like it became in the States last year. The situation is more complex for the rest of colorectal cancer patients, the 95% of non-MSI patients. For this population, new and promising strategies are being explored, and the selection of the appropriate patients to be treated with each of the combination will be crucial to maximize the effect of immunotherapy. Thank you.
Thank you very much for the fascinating presentation. So I will start with a general comment. I'm really frustrated because it took more than 30 years to move forward for the treatment that one size fits all in oncology. And then comes immunotherapy, and we are back in the beginning. So the only way, I think, is to make immunotherapy effective and cost-effective is to transform immunotherapy to a targeted treatment. And fortunately, in colorectal cancer, we don't repeat the silly things with PD-L1 expression and this type of nonsense investigations. So what you present, we try to correlate the biology and target therapies with immunotherapy. I think that is the way forward. My major concern is that with the exception of MSI high tumors that are homogeneous tumor, the bigger problem that we're going to face is heterogeneity.
Yeah.
And especially for the biallelic antibodies, we know that the metastatic cells are more frequent in EMT, they lose epithelial markers like CEA or EFCAM, and we should tackle this problem also.
Yeah.
But this is going to be the future, I think.
Yeah. Well, indeed, even the MSI high patients are not homogeneous.
Yeah.
We have a subgroup of MSI high patients that harbor JAK mutations, and these tumors are totally invisible for the immune system, and these tumors are unresponsive to immune checkpoint inhibitors. Recently, they presented a data that these tumors that don't respond to pembro or nivo respond to the combination of VP and nivo, and could somehow explain the difference in response rate from the combination or not. But yeah, it's true. The problem is that, okay, we had, at the very beginning, we started with chemo and radiation and all size fits all. Then we tried to understand the molecular biology of the tumors, trying to rationalize the treatment of cancer, and then we realized that we cannot understand the vast majority of tumors at a molecular level. Then immunotherapy is like, okay, I cannot understand the tumor, I cannot understand the immune system, I'm going to introduce each other and we fight together. Okay, but there's biology behind that. And there are some molecular mechanisms that lead to resistance to immunotherapy, and if we know that, we can really engage the immune system against these tumors.
Is there any question from the floor? Rob?
So,
yeah,
it may be very simplistic, but how come when you have, say, a PD-1 inhibitor, you have 2 or 3 courses, you have toxicity, you stop, and then the response is maintained?
Yeah.
So what's happening?
So that's very important, I think, and we need to change our mind, because I've been in several steering committees trying to design immunotherapy trials, and we are trying to deal with the immunotherapy as if it was chemo. Okay, so with chemo we need exposure of the drug, because if we don't have irinotecan in the tumor, we don't have tumor cell killing. But with immunotherapy we don't need a continuous exposure, because T cells are autonomous cells. If you activate the T cell continues doing its work. So if you engage if you show a T cell how to recognize the tumor cell, this cell will continue working in spite of you are not giving the drug. And also there is another level of complexity. If you engage too much the T cells, you force T cell killing by apoptosis, because the immune system during the evolution prefers not to react excessively against an inflammation than to react excessively, just to avoid autoimmune reaction. So if you engage too much the immune response, then you can cause tumor toleration. So it's even more difficult.
Okay, fine. So we're gonna to the next session.
Thank you.